I'm talking about analysis with MEG in functional connectivity in the fault mode network associated with neuropsychological rehabilitation in stroke. So just to give you a context, I am doing my thesis in vascular cognitive impairment, but today I'm just talking about stroke, which is just an event, an acute event. Here we have the ischemic and hemorrhagic stroke. It's important to have into account both of them, but the most prevalent is the ischemic one. It's almost around 80% of strokes in the world. So why it's important to study stroke is because it's the first and the second, so the first cause of death in men and the second in women in the world. Also increase the risk over 55 years old. The World Organization estimate that around 50% of the people over 65 years old will suffer a stroke. And for me as a psychologist, the most important data is that 50% of survivors suffer chronic cognitive impairment. So here is where I can do something in this illness. Also, it's important to know what is the fault mode network. So it's a network in the brain that is active during resting state and attenuated or deactivated during the performance of cognitive tasks. We can find this network around inferior parietal lobe, precuneus, and anterior and posterior cingulate cortex. So here you have a representation. It's also important to know that is already related with stroke. First, we have some studies that said that the fault mode network disrupts after the first stroke, and also it changes, or it improves or develops with cognitive recovery mechanisms. So in this way, we want to check the cognitive performance of stroke patients before and after neuropsychological treatment and compare it with healthy participants. The second aim was to study disruption and reorganization of the fault mode network, of course, again with MEG, of a stroke subject, also before and after the treatment. And finally, we want to correlate brain functioning with neuropsychological performance. So here you have the methods, briefly. We have 20 participants, 10 healthy control, 10 patients. With the inclusion criteria, we have the first stroke event. This is important. We need MRI to do a source reconstruction that we have, my peers have talked before. Then cognitive deficits, so they must show some cognitive deficits. And now have other neurological diagnosis, psychiatric history, or drug consumption. Then here we have the cognitive training. It was 7 months, and we take here the signal acquisition and also the evaluation, the neuropsychological evaluation, here in the pre-condition, and after the treatment, the post-condition. For the control subjects, we only take it one time, so the MEG and also the neuropsychological evaluation, because they didn't do any cognitive treatment. Okay, so here we have the results. We take 46 neuropsychological tests, and we found that of those 46, 12 scores mainly related with memory and executive functions improve between the pre and post, so after the treatment, even equating the control group, the control performance. Then 22 scores related with perception. They improve, but not as good as healthy controls. And 12 scores more related with verbal and arithmetic didn't improve, or not significantly improve. related with the functional connectivity, we found that interhemispheric hypersynchronization in beta band was found before the treatment in the posterior cingulate cortex. So this was one of the main areas in the default mode network. So here we found that participants before the treatment show an hypersynchronization in beta that removes or disappears after the treatment. And also this is related with the cognitive performance. So we found a correlation between, this is just an example of the results, but here we have the logical memory, so they perform worse in the precondition. After the treatment, they didn't have a significant difference with the control, so they improved their cognitive performance. And also, here we can find, or here, maybe better, that pre-condition, they show this beta hypersynchronization in the default mode network, and then disappear. So the post and the controls, they didn't show this hypersynchronization. And here we have like conclusions to have the ideas more clear. First, neuropsychological rehabilitation achieves improvements in the cognitive performance of stroke patients, even equating the performance of healthy participants. There is an hypersynchronization in interhemispheric connectivity of the posterior cingulate cortex in stroke patients that reverse after rehabilitation. This hypersynchronization in beta in specific areas of the default mode network correlate with lower cognitive performance. And finally, as a big conclusion or sum up, the results found in MEG reinforce and add a value to the role of neuropsychology, providing robust evidence of the influence of treatment not only in the cognitive level, but also in the neurophysiological base of the brain. So I hope you understand everything. If not, just ask me in the poster, please.